So I met Claudia Willliams at the health track at the South by Southwest conference, and I was struck how she was bringing a patient experience and social impact focus to her role in government. And now she's doing it again in the academic context at UC Berkeley School of Public Health, while also leading a dialogue with change makers in health through her podcast, The Other 80, which is just great, so you should definitely check it out. So I can't wait to hear what Claudia has to say. Please join me in welcoming Claudia Willliams.
All right, so I love this terminology we've been hearing about over the last couple of days of futurist imagine. And so I want you to put your futurist imagining hat on and imagine that Medicaid could be the systems change partner you've been waiting for. And I know, and we've been talking about this today, there are so many problems with Medicaid, right? There's lack of access issues, there's low payment rates, but I still think there's an opportunity to imagine into a future of better health with Medicaid as we go about fixing some of those other issues. So let's go on this journey together and see where we get. So this is a curve, two curves showing life expectancy over time. The bottom curve is the US, and it has a super frightening drop in about 2020. And you're saying, that makes sense. I mean, that was when COVID was hitting all of us. It makes sense, except look, the other countries don't have that drop. And so I think the simple answer is what's driving this drop, and there's been all kinds of stuff written in the Financial Times, the New York Times, science journals, is it was overdose deaths and COVID. Okay, so that's a simple answer. The much more complicated but more real answer is it's poverty, it's racism, and it's lack of investment in social services compared to those other countries. So I think if you're here, you've drunk the Kool-Aid, you know that the way out of that curve is not just more investment in medical care, right? We've been doing that. That number's been going up and up and up. The answer is to get to whole person health. The answer is more food, more community, more housing services as a complement to the medical services that we also need. And this, I have looked for the source behind this 80% number. Some people say it's 80%, some people say it's 90%. But I think we all agree that when we think about our own health, and we think about how much time we actually spend at the doctor or taking medications, for many of us, it's all the other things apart from medical care that really do inform our health. Here's another curve. My question is, could Medicaid shape and drive that change? And I think for many of you, that was probably not your first thought. Or maybe it was one of the thoughts, but it wasn't the main thought. And if you were back here in the 1960s when Medicaid covered just a few million people, that would be an unimaginably dumb thing to say. But today, Medicaid covers 83 million people, 40% of the people in my state of California, 40% of all births. That is a huge actor on the national stage of how we actually get this done. But there's another thing that's really important beyond those numbers. And this is something that Alan Weil said so beautifully in a podcast episode I did with him. And Alan, most of us think of him as the executive editor of Health Affairs, but he was a former Medicaid director in Colorado, back in the day, right? And Alan said, here's the thing. Medicare's like snazzy and cool. Medicare doesn't create new delivery systems. Medicaid does. And he went through a few examples, and it really got me thinking. He said, think about it. Back in the 80s, we developed home and community-based care services as an alternative to institutionalization. That had not existed before. New chronic care models developed over the last 20 years. So Medicaid has this power that's quite unique in this country to imagine and then create and then pilot and then copy new delivery systems. And some of the reason it has that power is it doesn't do it just once. We have all of these Medicaid programs. So someone can try it one way over here, another way over here. And when it works at its best, it truly is a laboratory for new changes in America. Now, that's happening with whole person care. So whole person care, I use that as shorthand to mean models where state Medicaid programs are combining offering of social services alongside traditional medical services. And there's always been some of this in Medicaid, right? We've paid for transportation, but it's really taken off, as we'll talk about here. So again, California is a leader in this. They have a program called CalAIM, and they are offering 14 social services that range from asthma remediation to sobering centers to housing navigation to food. But in addition, they put a really strong emphasis on fielding different kinds of teams. So Medicaid managed care plans, it's a state where almost 100% of people are in managed care, 99%, I think it is. So Medicaid managed care plans are fielding street medicine teams, they're doulas, community health workers, peers, and all different kinds of folks that are delivering on this model of whole person care. Now, I am not here to tell you it is all roses, right? This is really hard stuff. And one of the big questions that California is grappling with is, are they moving too fast? I don't have an answer to that today, but do tune in a few weeks when I have one of the Medicaid leaders on my podcast to talk about that question. Here's a picture of food distribution in North Carolina for the North Carolina Healthy Opportunities Pilots, a similar interesting model. 2 years into the program, which has initially focused on food, North Carolina found that for those folks that were participating in the program, their medical costs were $85 per month lower than other folks. Now, we don't want to just focus on costs, but that's a pretty dramatic change in a very short amount of time. So thank you, friends at Kaiser Family Foundation, who do a beautiful job of tracking so many things in healthcare, and just recently put out a Health Policy 101 that is not to be missed. This is a map of all of the states that have either approved or pending waivers. And remember, waivers is how in Medicaid land you get to do a lot of new things, to focus on whole person health, so social drivers of health. And what's interesting is this is not a map of blue states. We see red and blue states. We see urban and rural states. We see states that expanded Medicaid and states that didn't expand Medicaid. Now, admittedly, what is in the programs can be quite dramatic and large, as in California, or more narrow. But this is being adopted in an incredibly rapid way across states. One of the questions I've been pondering and thinking about on my podcast, The Other 80, is if what we're really trying to do is create systems change for health, what does it mean if the way we go about that is more individual services for social care? So we're paying for housing navigation. Well, we might really need houses. We're paying for medically tailored meals. We might really need better food systems. So this is a movement in the right direction. I think it's incredibly encouraging. But there's still a long journey to make to get from, and this is the public health in me speaking, get to the population health view of this. That's about the systems change, about the ecosystems, about the partners, about the underlying drivers of health, right? And so we are starting to see some Medicaid leaders ask that question. How might we actually start to focus on community health? Now, clearly that's going to take years, if not decades, to figure out, right? And you could also argue, as we started at the beginning, maybe Medicaid's not the best entity to drive that conversation. But guess what? They are creating that table and they're inviting people around it, and I applaud them for that. So I want to talk a little bit about what this looks like in California. And I think you have to kind of blur your eyes. I said the other day, it's like a pointless painting with like 10 of the points on it. You don't really see the image quite yet, but it's a really interesting to start to connect the dots to think about with all of those levers that a Medicaid program has. It has levers to regulate, it has levers to pay, it has levers to contract, it has levers to do conditions of participation, it has levers to offer threats, to give fines. So many different levers. So here's what things are looking like in California, which is very interesting. One, fairly uniquely in the country, not completely, but fairly, they have a network of regionally focused managed care plans. What I mean by that is a plan lives in one county and reports to the Board of Supervisors. They're not going anywhere. They're not going out of that county by being voted out of town in the next procurement. They are there to stay. And that has some problems. You can imagine, depending on what the Board of Supervisors is like, that could create new problems, right? But what it does is creates a consistent, permanent partnership between that organization and that community. They show up at all the local events where the health leaders and the community leaders and everybody else is there. So that's one. Number two, and this is a new requirement in California, all of those plans are now going to have to work with the county public health departments on community health assessments and community health improvement plans. They can't go off and do it their own, and they also are supposed to rope in the hospitals. So now you have public health, managed Medicaid, and hospitals working together to figure out what's going on in the community and how they could use their various levers and powers to make that happen. Then, the managed care plans have to invest 5 to 7.5% of their profits in community improvement. And guess what? If they don't reach their equity improvement goals, they have to put another 7.5% in. Now this, again, it could be a check the box exercise or something real, like let's make it real. But this could pay for housing, this could pay for new gardens, this could pay for building those food systems and other things that were identified as part of the community health improvement plan. And then last, and this is a little bit at a vector, but I think it could be a very powerful element, the state has now put forward a new data sharing requirement for the sharing of both social and medical data across the state. So again, these could be real or could be not real. But if you blur your eyes and connect the dots and make that pointless painting something real, this could be quite extraordinary and can be replicated in every single state. So I want to leave you with a few parting thoughts about how we might lean into this change. First of all, let's recognize and embrace Medicaid's ability to be a systems maker, new delivery systems, new things that they can spread and figure out what works. And let's make those new models be about the drivers of health. Number two, it's not about Medicaid coming in now and telling every community what to do. Wouldn't that be horrible? No, it's about giving communities the power and voice to make those decisions for themselves. And I don't think we've figured this out yet, right? I don't think a managed care plan is the right entity to start that conversation. But what could that look like? What could that governance look like at the community level? And then last, and I just love this quote from our Surgeon General, we're here because we love humanity. We're here because we want every brother and sister across the country to have the opportunity for thriving. So let's lead with that love. I would love for you to join me also on this journey. I interview amazing leaders with my team on the podcast, The Other 80, and it's been just such a delight to meet all of you and really feel part of a tribe here that's been brought together by Amy and Chris. So thank you so much.